Okay, welcome back. My name is Dr. David Kunashko. I'm a chiropractor and a traditional Chinese medical and acupuncturist. I've been practicing over 30 years now, but I've been heavily involved with photobiomodulation or low-level laser therapy or cold laser therapy, depending on maybe where you're from. The term photobiomodulation now is standard acronym or use now to describe what many people just refer to as laser therapy. And that's in the research now. So I will use the terms interchangeably, but everyone should be getting used to that term because that's sort of the research term and the established term that you'll see when you're trying to search for the new research. So today's topic is, excuse me, is on plantar fasciitis. It's a sort of an encore presentation I did a few years back, just updated with some more information. And, I've been seeing a few cases in the clinic here, and I get inquiries all the time from you guys about treating this very challenging condition. So I thought it was a good one to kind of review and go over again as well, because part of it is understanding a treatment plan and patient expectations and so forth, and understanding the pathophysiology so that both you and your patients can understand why this type of condition happens and why it's such a difficult one to heal quickly. If you have any questions, just type them in as we go along. I'll have time at the very end to discuss them. It's always Q&A at the very end. And I'm going to go over a little bit about the anatomy and pathogenesis of this condition, and then how photobiomodulation can help heal and reduce signs and symptoms. A little bit of research. Actually, there's quite a few. I just chose two particular articles to review, but there's quite a few others out there. And then, of course, specifically our protocols that Dr. Khan and the clinical team have developed over a period of time to help this condition. I've seen really good success with this condition, but I have an asterisk there because it's challenging, and it's just not one that typically responds quickly. So you have to be really persistent and patient with this condition, of course, and look at the biomechanical issues as well. All my webinars are recorded, and then you should get an email with a link to watch it again. Sometimes there's an issue with getting them out as far as people being on the list. So I'm not sure why that is, but you can always email me if you don't receive it, and I'll try and get you back on the list. But I don't know, there's some kind of glitch there that happens, but we do try and do that. It takes a few days for us to edit it and get that out to you. And if you can't ever join a webinar, you still want to watch it, then just register for it with your name and your contact info, and you'll get a copy of it. So even if you can't watch it the day of, for example. Looking at the anatomy of the plantar fascia and the plantar aspect of the foot, it's designed for shock absorption, obviously. The plantar fascia itself, of course, is not a ligament, not a tendon, but it's kind of in between. It tends to be broader and thinner. Now, the plantar fascia originates from the plantar aponeurosis that originates at the base of the calcaneus. And then it starts to fan out, as you can see with a diagram here. And it then sort of inserts into the distal portion of the foot, into tendons. And so by doing this, it provides a certain degree of shock absorption and rigidity to the foot. But of course, as we get older, or depending on what we do, and biomechanical issues, this tissue can be injured, especially over a period of time. It's not usually a one causal effect that's going to create the problem. It's a prolonged issue over one's lifetime or over a specific activity or sport or occupation or what have you. And then one day you wake up, or your patients wake up with pain in the sole of the foot, and they say, oh, I just, why this happened now? And it's not usually the case. It's usually that it kind of like arthritis is developed over a period of time. So it tends not to be an acute inflammatory kind of scenario, although there can be acute inflammation, but it's not really the case. The arch itself, there's two arches at the foot, as I'm sure you're aware. There's a medial longitudinal and a transverse arch. You need both of them. And with the medial longitudinal arch, that plantar fascia, you can see that yellow line at the bottom represents how it supports that medial longitudinal, and the weight bearing loading, all that weight, all your weight, whether it's 80 pounds of it or 380 pounds, it bears down on that fascia, and of course the Achilles tendon and other supporting structures as well. It's a dense connective tissue type of material. If you look at it microscopically, it's composed of well-organized collagen strands in parallel alignment. Now that's ideally what it should look like microscopically, but as we age and then we get microtrauma, it tends to become not so nice and organized in parallel fashion. So plantar fasciitis, or PF, obviously it's a fairly common cause of foot pain, especially in adults. Obviously there's pain, and typically, as we're aware, it's usually quite sharp first thing in the morning upon weight bearing, upon walking, or maybe sitting down for a while, then weight bearing after a longer period of rest. That's the sort of one of the cardinal signs of plantar fasciitis, and one that when you're doing your history, that will almost immediately, you'll start thinking about that's the cause of the person's problem. The pain itself is usually located at the plantar fascia insertion, but it can be unilateral or bilateral. It tends to be most commonly located on the medial calcaneal process of the calcaneus. That seems to be where, if you push in on the heel on the inside or the medial aspect, that's usually what elicits a fair amount of pain. Now, that's also a location for calcaneal spurs as well. Don't be confused if you get x-rays, and I know practitioners know this, but it's a good reminder that just because you have a spur doesn't mean that's the cause of the pain. In fact, most of the time that's not the cause of the pain unless it's quite large. It's usually just a sign of excessive stress at that calcaneal tubercle area. It does affect both females and males, and whether you're an elite athlete or recreational athlete. And it does seem to affect women slightly more often than men, probably because women are more active than men, doing stuff than us lazy men. So despite the diagnosis of being an itis, plantar fasciitis, is actually not so much an inflammatory condition. Kind of like when you think about tendinitis, and oftentimes it's a tendinosis that's the issue, not an acute inflammatory condition. So usually plantar fasciitis, unless it's a fairly acute kind of flare-up or tear that you can kind of figure out, there's usually an absence of inflammatory cells directly in that tissue, although there can be some, but it's not like a true itis where you have tons and tons of inflammation. It's more of a chronic issue. So more of a degenerative type of pathology. It's kind of similar to tendinosis at the site of that plantar fascia attachment, as I mentioned, at the medial tubercle. So it's usually described as an overuse injury, and as a repetitive strain, RSI kind of injury that causes that results from micro tearing in this plantar fascia. So as mentioned earlier, about 50% of patients, I didn't say 50%, but I mentioned about heel spurs. About 50% of patients will also present with heel spurs if you have an X-ray. So be aware of that. But again, laser therapy is not going to alter that spur. It can help if there's inflammation. So that would be a scenario where if the spur is large enough and in the right position, it can actually cause some localized inflammation. And laser therapy would definitely help with that, but it's not going to help resolve that spur. The spur is because of mechanical stress. And so it's not something that will just magically disappear unless you reduce that mechanical stress, and maybe the body will resorb some of it over time. So again, don't be thinking that it's the spur that's causing the problem, especially if there's a spur on the medial tubercle, but it's usually the fascia that's the problem. The fascia, as I mentioned, is quite disorganized. It becomes weakened. If you look at it microscopically, normally the fascia would present as type 1 collagen, as I mentioned, all parallel in alignment and nice and strong with good rigidity and response to elasticity. But with micro tearing and damage over time, it becomes much weaker. Collagen is usually immature type 3 collagen, quite disorganized. So it presents itself as being much weaker, which is prone to re-injury and very difficult to restore back to its normal healthy state, because it's taking years and years and years to get that way, usually. Location of pain, I've kind of mentioned this a few times already, but if you look at the plantar aspect of the foot, that red dot represents where that medial tubercle area would be. So that's usually quite the hot spot. And even at the plantar aponeurosis origin, you can see that's oftentimes tender as well. And oftentimes in medial arch area, your patient will present with some tenderness as well, but not as common as those other spots for sure. There can be an acute phase of plantar fasciitis, and that's usually when it's aggravated, it's really quite bad. And this oftentimes will turn into chronic phase because the patient just doesn't do anything about it. They just kind of, leave it alone or rest it up or take time off their activity, but the condition is still there. So it kind of goes into this kind of remission, and then it kind of starts to recur again. And again, there's a progression of degeneration that can occur, very similar to arthritis. When you look at runners specifically, this is a fairly common condition, up to 10% as a symptom, a condition that runners will report. The second only to shin splints and Achilles issues as well. So, if you're dealing with runners clubs, or, it's a great way if you're a runner yourself, or maybe take up running. And, we have a really great sales rep, Yogita, and she's a runner herself. And so she does a lot of events and everything. And she introduces laser therapy to these runners that oftentimes will have these problems and really don't know where to turn, or what even treatment to seek or even ask for when they go in for treatment. Of course, the more stress you put on your body, the higher the incidence. So, these ultra marathon runners who I have one locally where I live up here in Creemore, and she's always out there running. I never see her not running, and I'm just like, wow. But anyway, ultra marathoners have a much higher incidence of these conditions, obviously for obvious reasons. When you look at risk factors intrinsically, obviously there's biomechanical issues that are predisposed, like pes planus, pes cavus, overpronation, leg length discrepancy. Some of this stuff you can actually deal with through orthotics, or or referring to a good podiatrist or a chiropodist or chiropractor or physio that's been trained properly. As well. Of course, being overweight, you're going to put more stress on the plantar fascia as well. And then, of course, muscle imbalances. So you got to make sure your muscles are properly lengthened and stretching, gastroc, soleus, Achilles, of course. And then degenerative changes. There's a heel fat pad that degenerates over time as well. So that's a really common issue. So you tend to see it a lot in middle-aged runners as well, because there's less cushioning there. There's cushioning other places, but not so much in the heel of the foot. And you probably notice that too if you're older. When you kind of look at your heel and your heel pad, you go, oh, it doesn't seem as plush, you might say, as when you were younger. Well, that's that fat pad that starts to degenerate. Same thing around the knee as well. Extrinsically, there's incorrect training issues, too fast, uneven terrain, those kinds of things. So if you are into running and maybe you should have a bit of training, and maybe work with a group as well, just so your technique doesn't predispose you to this condition as well. So that's the thing that you should talk to your patients about, and make sure they understand that if they're just like a a weekend warrior and not really, paying attention to what they're doing, that's why they're ending up with these types of conditions. And of course, proper footwear is really important as well. So what does photobiomodulation do for this type of condition? Well, we know from a lot of research that it really helps improve collagen fiber organization and maturation. It does this over a long period of time. So you can imagine that it's very helpful to have a prolonged treatment plan, or sometimes the patients treat themselves at home and come in for a laser. There's lots of options that way as well. So what happens is that the laser therapy increases the metabolism of tenocytes, or it's a type of fibroblast that can increase type 1 collagen and help repair all that yucky, disorganized, immature collagen. It also downgrades MMPs, which are matrix metalloproteinases, which are which break down proteins, and they're a nasty kind of enzyme that we don't want. And if there's any inflammation around, I know that's not, I mentioned earlier, tends to be an acute inflammatory process, but it can be in other tissues around the area. But we know that laser therapy can definitely reduce inflammation. It can upregulate things like insulin-like growth factors. This increases cell proliferation and matrix remodeling. It can reduce fibrosis. Now remember, these things that photobiomodulation can do is over a period of time. One needs to explain to the patient that you're trying to remodel, trying to heal tissues that are injured, and not an injury like a torn muscle, more like a degenerative condition. So get out pictures, show diagrams. Like I think patients really like to see that, so that they can understand what it is they're dealing with, as opposed to just like, oh, you have plantar fasciitis and this is what it is. That type of information is really helpful for patients as well. And ROS, reactive oxygen species, this is something that is really critical in cellular function. Too little and too much, it needs to be in quite a balance there. When you have cells that have a metabolic disorder, there's too much ROS hanging around, and it creates problems for metabolism and the regeneration of cells as well. So photobiomodulation is known to modulate ROS production in a positive way. Looking at the research, I mentioned there's a couple of papers I'm going to present. One is I found really interesting because a shockwave therapy is one of the common ways of or therapies that are used out there for treatment of this condition. And I don't have a problem with shockwave. I like it a lot, actually. But it's not superior to laser therapy. In fact, if I had shockwave, I would be doing it first and then laser therapy. If I had to choose to buy a device, I would go with laser first, because laser has many more applications and indications and less contraindications than shockwave. So as a tool, that would be a much better go-to, because you can use it, it's more well-rounded. Shockwave having less applications for that. Anyway, that's my spiel about why you should choose laser. Well, of course, this is laser therapy, not shockwave therapy. But anyway, 60 patients diagnosed with chronic plantar fasciitis, and they were divided into 3 treatment groups. One had laser therapy, 8 joules, 830 nanometers, so definitely infrared. That's about the wavelength that we use. The energy density as well. Group 2 just had continuous ultrasound, which I used to use in my practice way back when I first started, and eventually I just realized I wasn't doing anything, or really not much that I thought was helping my patients. So I actually stopped using it. And then shockwave, 3 sessions, extracorporeal shockwave, 2000 shocks. If you know about shockwave, there's a number of shocks that you give to your patient. It sounds kind of barbaric. Well, it can hurt, by the way, and that's the other downside of shockwave, is some people can't tolerate it, especially if they're pain sensitive. But some people love the pain, so I don't know. There you go. So all the patients were assessed with VAS, something called a heel tenderness index, or HTI, the American Orthopedic Foot and Ankle Society ankle hind foot scale. Can you make these things any longer? The rolls, Maudsley score, whatever that is, and MRI before and 1 month after treatment. So success rate, 71% in the laser therapy group, that's really good, right? I mean, if you can have 70% success rate with chronic plantar fasciitis, that is extremely good. 65% with shockwave, good as well, but not as good. And a lowly 23% in the ultrasound group, which, to be honest, that's probably just time and function and placebo going on there. But anyway. So the next paper I presented is a updated one, and that's because it came out in 2019, and it was a meta-analysis and systematic review, which always has a lot more statistical impact when you're looking at a whole bunch of studies and looking at the overall conclusions, right? So these are the types of papers that are extremely helpful in pushing the agenda forward of seeing that photobiomodulation is helpful for these conditions. So they looked at almost 4,000 studies, like a huge number. 7 were randomized control trials that were eventually selected. I mean, it doesn't sound like a lot that were selected, but that's the criteria that they had to look at that it fit. And then after all of that, only 4 were selected. Again, whittling it down to ones that had good statistical analysis and were done properly. So the overall effect of photobiomodulation was statistically significant in the favor for thickness of plantar fascia reduction. So what they did was they took MRIs before and after, and they could actually see the fascia thickening and fibrosing, reducing or decreasing after treatment. So they concluded that this meta-analysis that photobiomodulation was an effective treatment modality to reduce pain, improve function in chronic plantar fasciitis. Now, what was also interesting is they found a wide discrepancy in dosimetry or dosaging. And so as always, when they start looking at these papers, they see ranges, some really low, some higher. And that's where some of the confusion comes in. And that's where it's really important to understand that when you're using photobiomodulation or laser therapy in clinical practice or at home or whatever, that you need to try different dosages. One doesn't always do the trick. And that's a big part of what we implement in our equipment, in our software, is a graduation of stimulations with dosaging and other parameters, because as these studies show, one size doesn't always fit all, and you oftentimes will have to change it up a bit and try different dosages. But there's usually a range, a window that we know that's going to be effective. All right, so moving on, how do we use BioFlex? What we recommend is a rolled up towel, put the array side up, the light side up, and have that patient gently place their foot so that opens up the arch of the medial arch, and you can treat over the plantar aspect that way. We do recommend a second placement as well, sort of curved around the heel, because there's lots of issues around the heel. And you can see the position and how it's strapped into place like that. Now, this first part of the treatment, some of you may know, and some of you may not know, this isn't lasers. These are superluminous diodes, red and near infrared. I'm going to talk about that shortly. And although you hear the term laser therapy, but the term photobiomodulation refers to photons of light. So this first part of the treatment is aimed towards the superficial tissues, any lingering inflammation, and for pain control. Whereas the laser probe, which is the last step of the treatment, is aimed to target the deeper structures and the deeper tissues into the deep fascia itself. Stage-wise, if you're familiar with the protocols, there's 3 stages in the professional systems. And the stages start off with the first step being that red light that's coming out of that array. It's on for about 5 minutes in a continuous wave. Then for the second step, we use infrared. So these superluminous diodes then automatically turn into near infrared. It's around 830, 840 nanometers wavelength. For this one, we actually pulse the light out at a specific frequency, a fairly low frequency, 10 hertz, and a lower duty cycle. The lower the duty cycle, the less energy, so less dosaging. And you might go, well, why? When you're first treating, it's always a good idea to start with pretty low dosaging, see how they respond. Some of these conditions can flare up if you overstimulate. So we tend to be a little bit more conservative on that approach. This part of the treatment is about 6 minutes. So right now we're into it for about 11 minutes. Now we're going to move that array from the sole of the foot to the heel of the foot and proceed similar like we did with the sole of the foot for 5 minutes continuous red, and then for 6 minutes infrared, a similar frequency and duty cycle. Then the very last step is using a class 3B laser probe. Our probes are around 200 milliwatts, but we can change the percent power. We use about 40% here, which roughly indicates around 75 milliwatts of power for about 6 minutes. Now that 6 minutes isn't all in one spot, that's moving it around, and I'll talk about that very shortly. So when you start treating patients, you need to start at that stage 1. And if the patient's responding well, then continue with the stage 1. If you've done 3, 4, 5, 6 sessions, not seeing a lot of positive changes yet, then you can move to stage 2. And stage 2 has increasing duty cycle. You can see it's at 80%, slightly higher pulse rate as well. And this is for the red now. And then for the infrared, similarly, you can see a higher duty cycle, 70%. So it's almost twice as much energy as the first stage, obviously more stimulatory, as well as a higher frequency or pulse rate, 30 cycles per second. I won't get into today about pulse rates. I've done webinars on it before, but it's an important part of treatment. And it's well known that certain cell types respond differently to different frequencies. And that really has to do with how metabolically active they are, how much mitochondria they have per cell kind of scenario. And then step 3 and step 4 would be similar to step 1 and step 2, but now we're doing it over the heel again. And then, of course, I'm going through this quickly, but it makes sense. And then step 5 is that laser therapy, but now we're at 100% power instead of 40% power. So we're increasing the dosaging again here to increase stimulation. The final stage, stage 3, you may need to use, it may not, it depends. Again, you need to be patient and give your patient time to respond. They're not going to respond, in a treatment session or 2. It's just ridiculous to think that someone's going to have a great result in such a few sessions when you're dealing with a chronic problem, right? The stage 3 is a really high stimulatory stage. The red is 100 hertz cycles per second, 90% duty cycle. Same time frame, 5 minutes. Whereas the infrared, now we're at a much higher frequency level, 250, although we could go up to 10,000. But for this kind of condition, we tend to keep it a little bit lower at 250 and 80% duty cycle. So again, pretty getting close to the highest amount of dosaging you can actually do with that infrared light. And then, so this is for the sole of the foot. And then, of course, you're going to do the same thing for that heel and that calcaneal area. Similarly, same red and infrared settings as well. And then the only change there is the infrared laser. We're at 100% power, but we're pulsing it out at 100 cycles per second at 90% duty cycle. So slightly less power, but because we're pulsing it out, that may have a little bit more stimulatory effect. So those are the protocols. Don't run through these protocols after a week. You should not be on stage 3 until many weeks have passed by. And you can even customize in between these stages as well to drag it out a little bit longer to provide stimulation, sort of less higher jumps, you might say, in dosaging. And that's something we recommend as well, and we talk about in training. Now, the laser probe, which if you have our equipment or maybe you have a competitor's equipment, that's usually what they would use. The laser probe you can apply to the tissue. You can apply firm pressure. That's important because you can actually push into the tissue and get it closer to the target itself. You're going to start by holding the probe maybe 5 to 10 seconds initially per point. And you're going to obviously treat around the medial calcaneal spur, around the aponeurosis origin, along the medial area of the longitudinal arch, any tender points, that kind of thing as well. So treat all along there, roughly 5-6 minutes of that laser probe, and you can go back to spots as well. You may need to increase the time per point if you're not finding this effective. It's pretty thick, and depending on the thickness of the patient's foot, you know how some people have really thick feet, so you may need to hold a little bit longer than people that have thinner feet, if that makes sense. The laser probe should always be held perpendicular and making good contact with the tissue. Try to pay attention to what you're doing, because if you hold it at an angle, sometimes the light bounces off the tissue and reflects off. Laser therapy is, generally speaking, a contact technique. Whenever I get asked about equipment that doesn't touch the skin, you know, you go in a booth and you have light held away from it, it doesn't make a lot of sense to me. Number one, almost all the research clinical trials touch the skin. So, you know, if you want to follow the research, that's how you're going to do it. And if you don't touch the skin, the law of physics come into play. 85% thereabouts of light just bounces off the skin, and less light will get absorbed unless you're using a huge amount of power, which, okay, fine, you can do that, but then you might start causing a heating effect. It doesn't make sense. So you need to touch the skin in order for proper absorption to take place. Again, you should hold that probe minimally 5 to 10 seconds, and you may need to increase that over a period of time. Don't forget to treat trigger points. Look at the calf, look at the Achilles tendon, you know, the whole lower limb. It's important to understand that might be problematic as well. And don't forget other things, right? Stretches, exercises, you know, all these different things can also play a role in healing. Our standard probe is infrared, but we also have another probe that's red. Red light doesn't penetrate deeply, and so you may wonder why you would even want to use it for this condition. It tends to be really good to reduce pain, to reduce unblock nociceptor pain fiber transmission. So it's not uncommon that a patient gets treated, especially with a red laser probe, and then they walk away going, wow, this feels great, I have no pain. And that's a temporary effect, which is nice. And it's part of the treatment process, but it gives a patient relief, but and better than taking a pill. You know, it's meant to be temporary, just to help out that patient with pain. If there's callus buildup on the sole of the foot, the sensor on the probe may have a tough time being triggered to stay on. If that's the case, just use your finger and touch the side of the laser probe to keep it on when you're treating the actual point. Otherwise, it might go on or off because it's a safety feature. In fact, we have that patented, and so it's a really important safety feature. But over callus tissue, it may have a problem turning on. So just use your finger as a guide to turn it on. When the patient first presents with plantar fasciitis, try and treat it on consecutive days if possible, 3, 4, 5 days in a row, and then 3 times a week until there's pretty good improvement. This may take many weeks for this to happen, and then start to reduce your progression to twice a week and once a week. Realistically, lay out the treatment plan over several months. Yeah, it sounds like a long time, but hey, this tissue takes a long time to heal. You know, it may be as few as 12, 15 treatments, but it may be as many as 24, 30 treatments. And it sounds like a lot, but it is. This condition is not going to go away quickly. And look at all the other issues, biomechanical, stretches, all these other things that are really important to address as well. If you have shockwave, I'm a fan. use it as well, but use it before, because then you're kind of stirring the pot, and laser therapy can help reduce any acute inflammation that shock wave has started up. Okay, thanks very much for listening in. I really appreciate you guys listening in. I do have a advanced training coming up on the cervical spine. Dr. Ben Ewan out of Halifax is presenting about traumatic brain injuries. I know he has a couple of case studies. Very interesting. He does a great job, along with Slava Kim and Nathan Chung in our clinic. They're going to be talking about rheumatoid arthritis and degenerative changes, osteoarthritis. I'll be talking a bit about disc herniation and radiculopathy of the neck and laser therapy as well. There is a $50 off that we have right now. So it's about $229, I think, which is pretty good. It's 4 hours for this advanced training. So if you can join us that day, that would be wonderful. We also have basic certification training coming up as well. That advanced training is on the Saturday, the 18th. The training is on the Friday, the September 17th. And we also have some other dates throughout the rest of the year. Just go to our website for that as well. Next webinar is posted. I have one on tennis and golfer's elbow, one for lymphedema, and one for hand arthritis. So be sure to sign up for those, register. Even if you can't join in that day, you'll still get a copy of it as well. So I do have some questions here. Do the applications and programmable stages described apply to the therapist system? Yes, so the therapist system has the same protocols in there and the same stages as well. If you're not, Athena, if you're not too sure about that or whatever, you can email me. I can certainly help you out with that, but you should be able to see all the different stages on there and choose the stages. How much relationship is there to tight calf muscles? Again, I'm not so sure as to how much of an effect tight calf muscles would have, but they would have a biomechanical issue there because of the shortening of the Achilles tendon, and that's going to throw out the mechanics of the foot. So you definitely would need to work with your patient to ensure that that those muscles are shortened as well. Okay, getting on to some other questions about a patient that might have lots of edema, maybe secondary to a heart condition, and how would the treatment be altered or changed? With edema, you can do lymphedema treatment, and that might be helpful. Of course, underlying cause, if it's due to, if it's due to a heart condition, you can't treat the heart per se, but you might be able to reduce some of the edema. The approach is the same, but if there's lots of edema through there, be patient, because you have to get through that edema as well. So you might want to treat a little bit longer with a laser probe. I have a question from Jill about, I think I kind of answered that, about issues with the posterior leg muscles and weaknesses and the ankle as well contributing. I always see these problems in patients with plantar fasciitis, mechanical issues. So I think it's all a contributing factor, to be honest. And there's probably so many of them there that you need to do a really thorough assessment to understand what it is going on with the patient and make all those alterations as well. I think if you did that, you'd have even more success with treating it as well. Do I have any visuals that work well with explaining to patients? You know what, I just pulled them off the internet, Sophia. You're free to use the visuals I have in this webinar. You can take screen captures when you rewatch it. If you want to do that, that's fine. Question from Mark, time frame for effective treatment for symptoms and versus causes. I would say symptomatically, you should start to see some improvement within a week or two. With respect to healing, we're talking many weeks and months. That's the time frame. We always seem to use LED before laser. Are there any occasions where you would just use the laser first? The reason behind using that large array of light is to promote a systemic effect and an analgesic effect, and also to saturate superficial tissues, the photoacceptors, so that the laser could go deeper. So generally speaking, we'll use that LED pad before we do the laser probe. For small areas, small joints, that kind of thing, you could just use the laser probe. Question from David. Hi, David. David, it's an RMT, oftentimes, well, hopefully is on some of these webinars. He's been a guest before. He is a patient coordinated with a dermatologist that's using shockwave first and then coming to clinic for a laser that same day. Is that okay? Yeah, absolutely. That's a good timing, actually. And secondly, my thought is to decrease any inflammation caused by shockwave and target. Yeah, exactly. So I think I covered that. That definitely using shockwave, do that before. Time frame, I think if you do it, the shockwave first sometime during the day and then the laser afterwards is good timing. So I think that's really good timing overall, David. Question from Kathy. I had plantar fasciitis November for about 5 months. Once I got my 120, it finally cleared up in about 2 months or less. Hey, Kathy, you know what? If you can do a little testimonial on that and send it to me, I will send you out a gift of some kind. I love testimonials, so send it out to me. That would be wonderful. I treated daily at stage 1, moving the pad around several spots. However, I did notice some discomfort on the top of my foot. Just doesn't seem to be going away. Wonder if this is something to do with the plantar fasciitis or something separate. You know what? It's interesting because there might be other underlying issues going on with that plantar fasciitis that once you start to clear one issue, you start to realize there's maybe some other issues going on through there. So that's probably what's going on. There might be some arthritis or some other issues mechanical wise or what have you that's sort of manifesting secondary to clearing that plantar fasciitis. A question from Mark or comment, how much does this does or does not apply to other foot conditions like metatarsalgia with respect to treatment settings in front of the foot? Yeah, well, you know what? I mean, if you're treating metatarsalgia, you would use a different setting. You would use the foot setting. So that's part of the difference there. A question from Peter. Hi, Peter. Are the protocols for the probe the same as the array? I'm not sure what you mean, but like, so the protocols for the probe, because it's a laser, they tend to be continuous wave, and of course, we tend not to be pulsing the light as much until the very end at that stage 3. So if that was your question, it's quite a bit different than the protocols for the array. And a question from Sophia, would tarsal tunnel syndrome or inflammation of that tunnel cause symptoms of plantar fasciitis? Yeah, that's a good point. I didn't mention differential diagnoses, but that is one of the differential diagnoses, a diagnosis for plantar fasciitis. So that would be something that you could look into as well, especially if it's not clearing up, and you may need to look at that as a potential cause as well. Again, Sophia mentioned that she has lots of plantar fasciitis in her clinic, and she has good success. You know what, guys? If you use our equipment and if you could be so kind as do a testimonial, send them in to me. I'll send you out something, whether that's maybe, I don't know, a free advanced certification training or something, but I'm not trying to bribe you, but well, maybe, but if you have good results, I'd love to hear about them. All right, thanks very much, everyone. I really appreciate you joining in, and we shall see you all next time. Have a great day.